Good morning. Thank you, Samira and Amila, for inviting me to do the lecture. This is, I will have to rush because there are a lot of things to discuss within 15 minutes. So I'm supposed to talk on diagnostic science and immediate management of orbital infections. Just to give you an introduction, this is actually considered as a specific inflammation with identifiable pathogens. Usually the orbital inflammation are discussed where there are no identifiable pathogens, but this is a specific inflammation with identifiable pathogens, and it includes there are two sections. It can be an infection of the periorbital tissues and or the infection involved in the orbit. And it is frequently leading to significant local and systemic morbidity. It has been found that about 10% of the patients will lead to loss of vision, and possible sequelae including meningitis that is seen in 1.9%, and cavernous sinus thrombosis, and the intracranial abscess in about 3%, and subdural empyema and septicemia. So just to show the two different types, either it can be preceptal or it can be orbital. We will be discussing the features in the next few slides. So thinking of the etiology, most commonly encountered organism is bacteria. The orbital infection can be due to viral, fungal and parasitic, but mostly the bacteria. Frequently encountered ones are streptococci and staphylococci. And it has been found, there's a difference between the children and the adults. It has been found that the children less than 5 years, preceptal cellulitis is more prevalent and most commonly due to ethmoisinusitis. And the average age for orbital cellulitis is around 7 years, with gender differences. The reason is not known. And the organisms are non-specific streptococci, non-hemolytic streptococci, group A, and beta-hemolytic streptococci, and Staph aureus, and Haemophilus influenza. But it has been again found out the incidence of Haemophilus influenza type B has decreased because of the widespread use of HIV vaccine started in 1991. And nowadays, of course, incidence of bacteria is very less, is less than 2%. And again, the pneumococcal infections are also decreased because studies done during the last 10 years have documented a decrease in the relative proportion of otitis media caused by streptococcal pneumonia. So the leading pathogens are now Staph aureus and Streptococcus species. And when you think of how to get the infection into the orbit, and it can be, there are three ways. One is the spread of infection of the neighboring structures. Sinus disease from the face, nasopharynx, lacrimal disease from preceptal cellulitis, especially in children, spreading into the orbit. So why it spreads so rapidly? Because there is a facial venous system with a vast number of anastomosis, and they are entirely valveless. And other method is direct injuries. It can be even minor surface injuries with necrosis of tissues, or penetrating orbital and sinus injuries, and iatrogenic following surgery. And it again can be hematogenous and is commonly opportunistic infection in immune-compromised patients, and something like subacute bacterial endocarditis. So this is just a picture to show the anatomic description. The top one is preceptal cellulitis is infection arising from in the tissues in front of the orbital septum, and the orbital cellulitis is infections coming up in the tissues behind the orbital septum. And when you get a patient, now the patient is there, so we have to evaluate the patient. So it includes a physical examination as well as ophthalmic examination. So it has been directed towards the localizing and identifying the potential source of infection. So look for things like sinus tenderness, lactocystitis, lactovaginitis, and otitis, mastoiditis, pharyngeal infection, etc. And look for meningeal signs as well. And in ophthalmological examination, and see whether there is a infection process is preceptal or septal. And the clinical features will help you to differentiate. So we look for things like redness, eyelid edema of periorbital tissues, that is in periorbital cellulitis, And there is a chemosis, proptosis with or without globe displacement, reduce ocular movements and decrease visual acuity and RAPD. They are all in favor of orbital cellulitis. And when you look at the fundus and retinal venous engorgement and papilledema, those things are in favor of orbital cellulitis with pressure on the globe. So at the same time, look over the vital signs, tachycardia, fever, and general ill health favor infection etiology. And but there are certain conditions where the normal temperature without any vital signs, a bit infection can be present. And also that needs cardiac examination to exclude the cardiac valvular problems. So other complications are the known complications, the cavernous sinus thrombosis, superior orbital fissure syndrome, intracranial infection, meningitis, subdural empyema, intracranial abscess, septicemia, and also secondary renal failure. So this has been, the sequel of this has been classified by Chandler's classification in 5 steps. So one is preseptal cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis. See the pictures just shows preseptal cellulitis. There is lid edema, there is inflammation of the subcutaneous tissue, and the edematous area is warm, tender, and taut. And they don't have proptosis, no visual impairment, no signs of orbital involvement. Now, this is orbital cellulitis, that all the signs are there. There is proptosis, lid edema, and chemosis, proptosis, visual impairment, all that is there. There are different patients. Then the CT scan in the middle shows that in simple orbital cellulitis, what the CT picture looks like, the tense proptosis, tenting of the globe, stretching of optic nerve. And these are all again, that there is this one, of course, this man, I don't have the CT, but in the middle, the CT scan, it shows ethmoid sinusitis, which is supposed to be the more common cause of orbital cellulitis. The next one is subperiosteal abscess. So again, all the features of orbital cellulitis are there, but there's a downward displacement of the globe. And if you can see the CT scan, you can see the collection of pus superior to the globe with globe displacement, and the down picture is the patient, it has come back to normal after surgery. And the other one is orbital abscess. There will be severe proptosis, and there is ophthalmoplegia, and the patient will have systemic toxicity, marked toxicity with the change of mental condition. And there will be features of orbital apex syndrome, the ptosis, proptosis, visual loss, external ophthalmoplegia, and corneal anesthesia, all that will be there. So the CT picture shows the collection of pus in the posterior globe space. And the other one is the cavernous sinus thrombosis. Is usually the bilateral symptoms, and there will be all the other features which I have explained. So those are the 5 stages that have been described. And this, I just want to show this one, that this patient came with periorbital swelling and diagnosed as periorbital cellulitis, but there was a small skin wound in the infraorbital region which has been gone undiagnosed and not thought of difficulty, but the patient was not responding, having continuous pain. And don't ignore this one, saying the superficial one. So we got the detailed history and then did the CT scan. It shows orbital foreign body. And there's one thing, the patient can come with visual loss. Of course, that is obvious. The reasons for visual loss will be proptosis, chemosis, clog of thalamus, corneal exposure. Other one is the mechanical compression of the optic nerve with the subperiosteal or intraorbital abscess and raised intraocular pressure. And there will be vascular occlusions, and there will be optic nerve inflammation and endophthalmitis. Those are the causes of visual loss. So we should not forget that not only the bacterial, there can be fungal infections of the orbit. So that can lead to grave complications. And although the primary site of the inoculation of the infective organism is frequent in the sinus, patients can present initially with the ocular symptoms and signs. So, and orbital fungal infection, they are not only vision threatening but also associated with high mortality. there are things to discuss. I have no time to discuss all these things, but just to say that most common orbital fungal infections are due to mucormycosis and aspergillosis. And this is, again, there can be different ways of spread. The primary orbital infections are extremely rare, but commonly the inoculation from the adjacent sinuses and maybe direct inoculation. Very rarely they can get hematogenous spread, and there can be inhalation from the respiratory tract also. And the risk factors are these: immunocompromised patient, diabetic, ketoacidosis, dysferrioxamine, all these things I have listed. The clinical features, of course, they will have fever, sinusitis, nasal discharge, epistaxis, all the orbital pain and all that. And in addition, they can have nasal mucosal ulceration, crusting and necrosis, and blackish over the skin, nasal mucosa or palate. But this is not an early sign, this is the late sign. So, now these are the pictures of people who have had fungal infections. If there is a patient with orbital cellulitis, you are treated with antibiotics and then the patient is not responding, or the patient is debilitated and with other debilitated conditions like diabetes, and if they are not responding, so you have to suspect that whether it is a fungal orbital cellulitis. So thinking about the investigation, I think once the orbital cellulitis is diagnosed, don't wait for to get the blood count and blood cultures and all that, because the important thing is start the treatment, antibiotics, IV antibiotics, and then go for the rest of the blood counts and things, because the blood culture counts, of course, will be high, but blood cultures, of course, it's not really necessary. Generally, we don't get positive cultures in all the time. But in addition, minimal invasive culture techniques like nasal swabs or the eye discharge cultures, we can get positive results from that. And the patient is debilitated, look for ketoacidosis, arterial blood gas, all that you do while the patient is managed with the drugs. And of course, CT imaging will have a place in orbital cellulitis. CT is very easily available and cost effective. And now it is recommended that you use a low dose as much as possible, especially in children. And generally the contrast is required. So MRI scan and the CT scan will give you the indication about the involvement and whether there is a collection of parts, whether there is optical compression, all that will be given by the imaging, and we can plan for the rest of the management. And in addition, we might need the nasopharyngeal endoscopy, especially in cases like fungal endophthalmitis, fungal cellulitis. And the treatment, of course, uncomplicated orbital cellulitis treatment is with antibiotics alone. It is IV antibiotics, and usually the antibiotic may have to continue for 2 to 3 weeks. But if there is severe ethmoid sinusitis, bone erosion, we may have to continue for about 4 weeks. But IV antibiotics for about 3 to 5 days. Once the orbital inflammation signs settles down, you can change over to oral drugs. I have listed the usual the drugs we use: ceftriaxone, cefotaxime, and ampicillin, sulbactam. And in addition, of course, you have to combine with metronidazole to cover the anaerobes. So if the patient has MRSA positive, to cover that, we have to give and start with vancomycin. If there is a case of a patient with penicillin allergy and cephalosporin treatment, in combination with vancomycin has to be used in combination with ciprofloxacin. So oral therapy, I think, just want to say, I have not discussed the details, of course, it's always can take it down. Oral therapy, of course, in uncomplicated orbital cellulitis with good transposed IV treatment, switch over to oral therapy within 3 to 5 days. But if the culture medias are not, if the definite culture medias results are not available, appropriate treatment would be clindamycin, maybe alone, or with trimethoprim sulfur methoxysol, and plus there are some other 2 new drugs we can combine with them. Treatment of fungal infections, again antifungal drugs I have just mentioned. An indication for surgery is, one thing is evidence of an abscess with compression of the optic nerve, and suspected fungal or mycobacterial infections, and if there is intracranial infection. The differential diagnosis, I just want to mention this, and there are few cases that is important for you to differentiate. The top one with the man with he is having actually is a caroticocavernous fistula, but as when you look like, you might think that it is a severe orbital cellulitis. The girl's picture down, that again she came with, one of my patients came with acute onset of proptosis, but there was no complaint of pain within 2 days. But of course, as we see that patient, we think that it is a orbital cellulitis, but there was a palpable mass in the superior orbital region, and it came out to be a rhabdomyosarcoma. And other three, the next slide, and all these things actually, the patient come with proptosis and the downwards displayed when they go, pain and everything. But they all three are following trauma with orbital hematomas, but it's not orbital cellulitis. Those are the important cases where you have to differentiate. Thank you.